Hey, good afternoon. Can you hear me well?
Yes.
Oh, perfect. So it's a pleasure. Thank you again to the Hunterscope Foundation for the invitation. So we can move to the next slide. So as you heard over the last 2 days, leukodystrophies are very heterogeneous diseases. So early when we start working with the Hunterscope Foundation, they sent a survey to over 300 families to try to have a better understanding of what kind of issues patients with leukodystrophies have. And I just pulled out some of the data from the initial survey. As you can see, probably like around 60% of patients have some issues with aspiration and swallow with dysfunction that will affect the long-term pulmonary function. 50% of them will have scoliosis, as Dr. Evans just mentioned earlier. Scoliosis will potentially affect the lung parenchyma and also the lung mechanics, and will affect breathing in the long term. And many times these patients will be dependent of some kind of degree of respiratory supporting, going from oxygen all the way to non-invasive or invasive ventilation. Along the same, we have hypotonia, recurring pneumonias or respiratory infections. There's a significant number of patients that develop apnea during sleep, like around 40%. And then interestingly enough, there was like around 1/3 of the patients that were dependent on oxygen, maybe dependent on like a CPAP or a BiPAP, which is non-invasive ventilation. A significant number of patients with drooling or siluria and inability to cough. So after that, we're trying to have a better idea in the pediatric population more than anything else about what kind of like support they have at home. So if you think about with the initial survey, we were wondering about just has any patient had developed apnea, has any patient had like any respiratory problems. We're trying to deep a little bit more into what kind of medications they might be using, if they were being followed or not by your respiratory specialist, if they were requiring a ventilator or not, if they have a sleep study or not. So can we move to the next slide, please? So this is the survey that we had last year. It wasn't a smaller number of respondents relative to the initial one with 300 subjects. But as you can see, one of the questions was if like, the patient has been admitted to the intensive care unit for respiratory issues. And there is a significant number of patients that they were admitted to the intensive care unit. We also ask about devices that might help for ineffective airway clearance, which is something that we've been using for patients with neuromuscular disorders for many years. And there is a significant group of patients that they use what is called a chest vest device. That basically what it does is starts producing some high frequency to the chest wall to provide the shear forces into the mucus that will decrease the viscosity and will allow to improve in airway clearance. We also ask about having a cough assist device, which is particularly important in patients with a certain degree of hypotonia, where the respiratory muscles are weak enough that when they have a respiratory infection, the ability to clear the mucus is impaired, and this will lead to recurrent respiratory infections, pneumonias, and subsequent lung damage. We also ask if patients had or not a suction machine. As you can see, the vast majority of patients have an oral suction machine due to the issues with drooling. And as I say, drooling tends to lead to microaspiration that leads to respiratory or pulmonary inflammation, and then potential issues in the long term. If we move to the next slide, please. We also were talking about how do are we controlling, or they are controlling upper airway secretions or drooling. So we're asking about if any patient has been using glycopyrrolate, scopolamine patch, or Botox, which are one of the most common medications currently used for the management of drooling. And as you can see, there is a fair number of patients that were using some kind of medication, but a significant number of them that were not. And that was an interesting question about like, should they be using it or not, since the vast majority of patients were already using some kind of oral suction machine. Also, we ask about if there is any apnea or sleep disorder breathing symptoms, and a significant number of patients do have apnea symptoms. And then we move on to see if they have like an objective measurement to see the severity of this apnea. This is done by using a sleep study or polysomnogram. And there was just a small percentage of the subjects that responded that they have apnea that had a sleep study, and this might be due to the limited number of sleep labs in the country, depending on the location. And there might be some providers that might not be aware of the importance of any sleep study. And perhaps beyond that is also what to do once the patient has an abnormal sleep study. What will be the next step? Is this to go to maybe an ears, nose, and throat doctor for an evaluation of tonsils and adenoids and the other potential cervical management, or the use of a CPAP machine or a BiPAP machine. And then the last question that we ask is if there is a pulmonologist or a respiratory physician that is involved in the care of patients with leukodystrophy. And I will say that there is probably a small percentage of patients that are being followed by a respiratory physician. Can we move to the next slide, please? So after these and after having significant number of meetings, initially with a larger group and then eventually with a smaller group of people involved in developing the guidelines, we decided to write a manuscript with the guidelines for the respiratory care of patients with leukodystrophy. One of the main issues regarding the leukodystrophy population is that the data, at least the respiratory data, is very limited. Most of the data that we use for developing the guidelines come from patients with neuromuscular disorders, which they share somehow a similar physiopathology that patients with leukodystrophy with some degree of hypotonia, other patients having some issues with molar muscle dysfunction as well as aspiration, and along the same lines, extrapolating data from other disorders that might affect the nervous systems, even including patients with static encephalopathy. We decided to base the guidelines into management of drooling, providing some recommendations about airway clearance, including the use of certain devices to improve airway clearance, about the sleep disorder breathing, how to screen for sleep disorder breathing, how to diagnose sleep disorder breathing, and then beyond that, the use of non-invasive ventilation or home ventilation. We initially also discussed and had topics about swallowing dysfunction and the role of gastroesophageal reflux disease, as well as scoliosis. But then after an evaluation, and since there were other groups that were working on this, we decided to leave it for our guidelines for a different topic. And then the last part is how to integrate this team-based care. So with patients with complex disorders, often the care is very fractionated. So patients will be seeing the neurologist, and eventually they will be seeing the pulmonologist or physical medicine. And there is perhaps nobody that integrates all of that. So it's a very fractionated care where people are not talking to each other. So we're trying to come out and provide some recommendations on how the team should work together, involving as part of the team family decision-making, depending on beliefs, the ability or not to have different kind of technology or devices, among others. Can we move to the next slide? So let's talk a little bit about secretion management. So in patients with neurological disorders, there's two issues of why they have drooling. One is an increased production of saliva, but also swallowing dysfunction leads to an impaired process of the saliva, and there's accumulation in the saliva of the mouth with potential microaspiration that will lead to inflammation and more saliva production. So the first line of therapy is to use medication. The most common medications are glycopyrrolate that can be given by mouth or by EG to scopolamine, which is a patch that can be applied behind the ear, and then Botox, but also atropine. So this is usually, again, the first line. What we recommend is to go with one agent at a time and to maximize the dose before moving to a second medication or a third medication. We often see patients that are already taking glycopyrrolate, but they are taking at a low or medium dose. And since there is not a positive response, we move to the next agent, scopolamine or even atropine, instead of maximizing one agent, and then we go to polypharmacy, which will increase the potential risk of side effects and interactions with other medications. Regarding glycopyrrolate, perhaps the most important thing to remember is side effects depending on the dose, and also tachyphylaxis or tolerance. The dose will need to be adjusted over time because patients might become kind of resistant to that dose. The most common side effects tends to be very dry secretions and occasionally mucus plugging. And then beyond that, also issues with urinary retention. The scopolamine patch works great. The only problem, especially in the pediatric population, is that the patch the dose in the patch might not be appropriate or might be too high for children. So then the patches need to be covered, like you can do like a quarter of a patch or a half of the patch, and half of the patch will need to be covered. So, or it could be cut to apply it behind the ear. Botox is the next line. As you can see in the picture, it will be applied in different glands, and this can be done with the aid in ultrasound or with a very experienced interventional radiologist, or sometimes even when I was at Children's, Sally Evans will be able to do it just in the procedure room or in the OR. The advantage of Botox, as I said, it is very effective, but it needs to be done either every 3 months, every 4 months, or every 6 months, depending on the response of each patient. Also, atropine drops can be used. One of the potential issues with atropine drops is that dosing. If there's a mistake with the dose, it could potentially create side effects, so it's tricky. The next step is to it's more invasive surgery, so you can do salivary gland ligation. The problem with that is that sometimes there is a hypertrophy of other glands and more production of saliva. Now, there is a new modality that is being used over the last few years where you can embolize some of the glands, and it's less invasive than surgery. But again, it has some of the potential issues with hyperplasia or hypertrophy of the other glands, and again, production of saliva. Is very, very, very rare where there would be a recommendation to do a laryngotracheal separation where the airway is separated completely from the swallowing part of the esophagus. But again, this is a very invasive procedure that is very rarely recommended, and is just indicated in patients with recurrent respiratory infections or aspiration pneumonias. Then we also talk about suction, what kind of suction you should use. Initially, the recommendation is to use oral suction with a Young Howard. Be careful with using deep suction or using catheters to deep suction because of the potential issues with the vagal response and drops on heart rate, also creating some gagging reflex and potential issues with vomiting. There's issues with what kind of equipment is needed. Most portable suction machines, as expected, are run by electricity. And then there are some issues with some parents will like in the middle of like a soccer game with the family and they didn't have access to the suction machines. So it's a question about how else you can suction the oral secretions. Frequency, how often you should do it. In general, it can be done as needed to try to control the secretions, but there is always the question of when to start medication if the secretions are increased. Again, most of the recommendations are trying to align with quality of life and to provide at least the advice that despite the fact that these patients might need a lot of equipment or medications, they can also have a plain quality of life. They can go outside, they can go with the family to soccer games, as I say, or like during the summertime camps or other things with the aid of different equipment. Can we go to the next slide? So let's move to airway clearance. This is something that, as I said, we extrapolated most of the data from neuromuscular disorders where we have plenty of experience on how to use different devices to improve airway clearance. So one of the main parameters is to ideally use pulmonary function testing, but this is sometimes difficult for patients that might have some degree of neurological impairment, or they might be too weak to perform pulmonary function tests. In patients that they can do pulmonary function testing, again, we would strongly recommend to use a spirometry or to measure maximal inspiratory and expiratory capacities, as well as the peak cough flow, as you can see in the bottom picture of a patient where we're measuring the peak cough flow. Based on those numbers or in the data from pulmonary function tests, we provide certain recommendations regarding what type of devices or equipment patients should use. As I mentioned, the devices that we recommend, perhaps the most important one is called the cough assist device or inexsufflator. This is recommended for patients that have very weak inspiratory and expiratory muscles. The cough might be adequate, so assessing sometimes the cough at the bedside is difficult with the lack of pulmonary function tests. However, asking the right question is very important. This is not about like if the patient is coughing or not. It's about how strong the cough is. If the strong is not strong enough to mobilize secretions, then the patient will be at increased risk of developing complications from common respiratory infections like colds, such as atelectasis, mucus plugging, or even pneumonia. The cough assist device is a device that it will use a mask and it will deliver positive pressure to the patient to increase the total lung capacity, and it will generate a negative pressure, kind of like a suction or a vacuum, very fast within a second to try to mobilize the secretions from the large or medium-sized airways all the way out. And the patient will either try to expectorate, you can suction it with a suction machine, or eventually they can swallow it. The other one is the use of a chest vest, or as I say, the high frequency chest wall oscillation versus the device called an intrapercussive ventilation. There are new smaller devices that are similar to intrapulmonary percussive ventilation, but it tends to be limited more to hospital-based setting. So for home, a chest vest device could potentially be used. Also, there is a role to do manual chest PT, just tapping on the chest. It's very effective with positional drainage. The only problem with manual chest PT is that it takes like around 20 minutes to perform. And sometimes it tends to be cumbersome from families. So using a chest vest device might be helpful along with a cough assist device. There might be some patients that might benefit just from using the chest vest device or manual chest PT. They have a strong cough. So the chest vest or manual chest PT, what it will help to do is to decrease the viscosity of the mucus, so it's easier for the patient to cough the mucus out. So it's important to evaluate what kind of device you want to recommend to your patient. And as I said, patients with leukodystrophy are very complex. So a lot of times they're already taking many medications, or they're using devices, or they're dealing with seizures, et cetera, et cetera. So it's important to decide at what time you're going to start one or another therapy. So it will be less stressful for the family and sometimes even time consuming. Next slide. So let's talk a little bit about the sleep disorder, breathing, and chronic respiratory failure. So it's very important to ask questions about the sleep in the clinical visit. This goes beyond just like what time you go to bed or not, but focusing more about like apneas, pauses, noisy breathing at nighttime, evaluating physically the patient to look for like a big tongue or microglossia, to see are there any changes in the nasal septum, to evaluate the size of the adenoids, the tonsils, to see the shape of the neck, to look for suprasternal retractions, and so on. In the ideal situation, if there is a suspicion for sleep disorder breathing, the next step is to order a sleep study, which is the gold standard for the diagnosis of obstructive sleep apnea, hypoventilation, or any kind of sleep disorder. Also, the polysomnogram will be able to assess the electrical activity of the brain during the sleep. And we can even potentially sometimes diagnose seizures that happen at nighttime when we use the seizure montage during the sleep study. There are, as I mentioned earlier, there are some limitations about sleep studies. This was a big deal during the COVID pandemic because most sleep labs were closed. We learned a lot during these 2 years. There's been a lot of experiences in other countries where there's a limited number of sleep laboratories. So perhaps using an oximetry study as a screening tool, it might be something that is helpful. Basically, what we can do is order a 2 or 3 night oximetry study at home where the device will record the heart rate and also the O2 saturations overnight. And if there are significant desaturations, if there is a desaturation index that goes beyond 4 or 5, then as a screening tool plus the clinical scenario could be already a recommendation that can be used to prescribe a CPAP device or a BiPAP device. The management, as I said, everything depends on the clinical evaluation. For some kids early in life, if the tonsils and adenoids are large, the recommendation is to have a tonsillectomy and adenodectomy. The advantage of doing this, even that is a surgical procedure, is that the patient afterwards will likely improve and there will not be a need to use any medication. That said, because of the progressive nature of leukodystrophies, a patient might initially have just pure obstructive sleep apnea. Later on in time, might develop nighttime hypoventilation and might still require a BiPAP or a CPAP device. Again, if surgery is either not an option or is not indicated, then non-invasive ventilation is the next step. This can be either a CPAP, which will provide just continuous positive airway pressure, or a BiPAP. The CPAP or BiPAP, ideally, they should be titrated for each patient. Again, the gold standard will be to have a titration study in a sleep laboratory, but there are certain limitations, the same thing that with the initial sleep study. So now most devices have the capability of record data and to provide an apnea-hypopnea index, which is not as good as the one that we get in the sleep study, but they might be helpful to titrate some of the settings in patients that are not able to have a titration in the sleep lab. As you can see again in the pictures, it's just the standard montage for a patient with that is going for a sleep study. And then you can see in the bottom picture a patient with spinal muscular atrophy where he has a nasal mask for a BiPAP. We always need to talk about the complications of non-invasive ventilation, which sometimes include some lesions in the nose where the area is making contact with the face. Occasionally, they may increase in oral secretions, or because the flow or the pressure of the air is going out through the mouth. Some patients might feel uncomfortable with the use of the mask, so they might not tolerate the mask. So there are other alternatives, sometimes even using just a nasal cannula with oxygen might be a treatment option. Next slide. Something that is very, 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 very important for non-invasive ventilation is a good mask fitting. The mask a lot of times makes a big difference in somebody that is not tolerating a device. I often see patients that they come to clinic where they're like, yes, the CPAP or the BiPAP never work. It's impossible. This doesn't work. It's a very loud machine. And again, if the machine is loud, it's telling you there's a big leak of the system, and this is something that can be fixed. So you click one more time, you will see the different types, thank you, of the different masks for adults to kids. So the fitting is usually done at the bedside. You try different masks to make sure that there's a good mask fitting, that the machine is quiet. And from there, you will go to the titration if you have to. But I will say that most of the time, once you find a good mask that fits quite well, most of the time, the CPAP or BiPAP tends to be well tolerated. Next slide. The devices, there are many devices in the market, depending on each situation. So on the top, you have the most common either CPAP or BiPAP devices. And in the bottom, you have one of the most common ventilators that can be used for non-invasive or invasive ventilation. There are certain advantages and disadvantages from them. The advantage, obviously, of a ventilator, such as the Trilogy and the Astral, is that it has alarms that it will tell you the mask came up of the face or not. I can also record more data, and it can provide more than just one setting. So sometimes we can have like what we call 9 times settings, 6 settings. In somebody has a cold, we could potentially have a different kind of setup to help the patient overcome that cold instead of like just bring them into the hospitals where we have to increase the settings for that, or we could potentially use more complex settings on a ventilator that again will have the goal of providing extra support when a patient has a respiratory infection. Next slide. So how long can you support non-invasive ventilation? This is a very important question. Can you do it for 10 years, 1 year, 6 months? And again, this depends on many factors. So it depends on the family. It depends on the experience of the physician. If the physician has a lot of experience and so can support non-invasive ventilation, obviously the disease severity. If there is issues with bowel dysfunction, mainly there is issues with controlling secretions, aspiration, if the patient has a lot of problems that cannot tolerate the non-invasive ventilation. How many hours per day is extremely important. Once you start using a BiPAP or a CPAP for more than 14 to 16 hours per day, you start having issues with the interface and having issues with lesions in the face, the quality of life of the patient, etc. And then last but not least is ventilator and tracheostomy. There are certain indications, with the most common one is that if non-invasive ventilation fails, then ventilation and tracheostomy is indicated. It depends on the kind of support. Remember that the patients are going to need, or the families are going to need extra aides, nurses, LPMs, and obviously the equipment, they need a backup ventilator, oxygen monitors, tracheostomy And all of these decisions need to be taken in conjunction with the family, including what is important for them in regards to quality of life. Next slide. Again, regarding improving team-based care, as I say, like this is the communication between primary care physicians and subspecialists. We still think that the primary care physician should be involved with patients and should try to coordinate with subspecialists. This is just a table about who should they be seeing, who should be managing one or other parts. Again, there might be areas where there are no pediatric pulmonologists in the country, but they can always find somebody, even at the Hunterscope, will be happy to do like a remote consult or like a telehealth visit just to try to provide support. And then eventually a pediatrician or a complex care physician could start helping in the care of patients with leukodystrophies. Next slide. This is just the initial working group. There's more people now involved in this, but I just want to acknowledge some of the people that work early in life. Early in the developing of the guidelines. And then the next slide is just again to acknowledge Chad and Lisa, who were the steering committee from the Hunterscope Foundation that were very involved during the developing of the guidelines. And next slide. This is all I have. If you have any questions, please feel free to contact me.
All right, thank you so much.